This was such a fun discussion with Dr. Barry Krakow. I was honored to have him on the channel because he's a world-renowned sleep specialist. He's a prolific writer and researcher. He's authored some seminal papers in sleep medicine. Today we're exploring nightmares and Nightmare Triad Syndrome. Dr. Barry Krakow is a board-certified sleep medicine specialist practicing in Savannah, Georgia, following a 30-year career in conducting research in psychiatric patients with sleep disorders and treating those individuals with evidence-based pioneering techniques to optimize care. His recent book, Life-Saving Sleep, New Horizons in Mental Health Treatment, integrates this new approach to sleep treatment. His current practice involves innovative sleep coaching. If you are a physician or a clinician who wants to uplevel your sleep medicine knowledge, go ahead and subscribe to this channel. I'm Dr. Nishi Bhopal. I'm a physician specializing in integrative psychiatry and sleep medicine. Watch all the way to the end and then use the Learner Plus link to get educational credits for watching this video. If you want to learn more about how to use melatonin in your clinical practice, get my free melatonin brand guide at intrabalance.com/melatonin. All right, without further ado, let's jump into today's discussion on nightmares with Dr. Barry Krakow. Dr. Krakow, I am really delighted to have you on the channel today. You have such a wealth of knowledge and expertise and clinical experience. So I'm really looking forward to this conversation. Maybe we could start by you sharing a bit about your background. How did you get into sleep medicine?
Certainly. Thank you very much for having me on the show. I think the answer to most questions in life are divine providence. Being an emergency medicine and physician and an internist, I certainly wouldn't have expected this because back in the 1980s, my goal was to be a novelist and a screenwriter. Instead, I ended up working with two psychiatrists in the Department of Psychiatry at the University of New Mexico School of Medicine in 1988, where they were developing a non-drug treatment for chronic nightmares, known as Imagery Rehearsal Therapy. And as things turned out, I loved it so much, I said, well, what else can I do with this? And I suddenly discovered the field of sleep medicine and realized that was the field that I wanted to go to because I also knew I had my own sleep problems. But that wasn't why I did it, because I never even treated my own sleep problems, because as we all know, doctors are horrible patients. And I took about a decade before I treated my own sleep problems. Anyway, that's how I got into it. And I ended up taking over the research because Dr. Kellner, who started it, he passed away in 1992. And Dr. Neidhart, the other co-investigator, went off into private practice. So I was working at the University of New Mexico, and I continued the research from that time around 1990, 91 for several, hold on just one second. And so once I got into it, the remarkable part was that I could take sleep that I was learning about so I could become board certified in sleep. And that took several years because back then we could do grandfathering, but there's all kinds of steps that had to be taken. And I could start to see that in relationship to psychiatry. So the perspective I brought was a very open-minded internist perspective of give me the differential diagnosis, give me the differential diagnosis. And that served me very well, as we'll get into in the conversation.
Excellent. Thank you for sharing all of that. And for anyone who doesn't know, Dr. Krakow's research has been really seminal in the treatment of nightmares. He published the first paper, I believe, on imagery rehearsal therapy for nightmares. And today our focus is going to be, there's so many things we could talk about, but our focus is going to be on nightmares and Nightmare Triad Syndrome. So maybe we can get into what prompted you to research nightmares. I know you have a special interest in that and trauma, mental health, and the intersection of sleep. How did you get into that?
So when Dr. Kellner started this program in 88, he had seen a few individual cases of nightmares and had treated them on his own with imagery rehearsal therapy. And he was shocked by the discovery that if you treated somebody's nightmares, their mental health got better. Because back in the 1980s, people didn't talk that way. They said, you have depression, you have anxiety, you have PTSD. We're going to treat that, and your nightmares should go away. And that research itself has some validity, but overall, people were never looking at nightmares as this big deal. You had to be in a certain field like dream research or psychodynamic psychotherapy to say, let's talk about your dreams. So it got pushed aside. When Dr. Kellner and Dr. Neidhart and I published this first paper in the American Journal of Psychiatry, in 1992, it actually showed if you treat nightmares, you, in a randomized controlled trial, you decrease anxiety and you decrease depression. And this drove them, these are psychiatrists. Now, I'm an internist at the time, right? Not even a sleep doctor yet. This drove them wild. This is an amazing therapy. We never get results like this in the stuff that we do in psychiatry. And here we are, we're doing this simple technique, teaching people how to rescript their nightmares. And now their mental health gets better. Before Dr. Kellner passed, he and I had multiple discussions in 1991 about how are we going to capitalize on this research, because it really has to be done more thoroughly, more larger population, et cetera, so that it actually gets disseminated. And so I did more studies up in Santa Fe, where I was living at the time. And then I finally moved back down to Albuquerque later. But the last thing he said to me in one of our last meetings was, you've got to do this study in PTSD patients with PTSD nightmares. And he said, you've either got to pick veterans or you've got to pick rape survivors. It's got to be one of the two, because that's what everybody's researching. And as the way it happened in our particular facilities, it made much more sense for me to work with sexual assault survivors. That's the study that we did that started in 1992. And then we got this huge grant from NIMH in 93. That study lasted several years. It got published in JAMA as the lead article in 2001 for one reason. When I talked to the editor about the paper, he asked me the question, tell me, why do you want to publish this paper? We're JAMA, we do these special issues on PTSD, but what's the hook? And he goes, I go, we treated PTSD patients' nightmares, and you may not believe this, but their PTSD got better. And their PTSD got better big time, at a level actually equivalent to what a lot of people were using when they prescribed drugs. And he goes, oh, I want the paper. And this was like in June, and this was a special issue JAMA does every August. And they said, get it to me right away. We got to review it right away, because this is a paper. It ended up being the lead article in the August issue of JAMA. And yet, and maybe we'll get into this as well, that even though it showed that imagery rehearsal therapy works extremely well, even on PTSD nightmares, that knowledge has not disseminated. That's now 25 years, has not disseminated into the mental health field unless you're in a specific niche. So if your niche is the military, where you're doing mental health and you're seeing all these people with PTSD and nightmares, all those people learned about IRT. All those people contact me for resources about IRT. I've done multiple trainings around the world at military bases for IRT, and they're embracing it. But if you go out into the other part of the communities, different cohorts of mental health providers, it's like, how do you treat nightmares? Oh, that would be psychotherapy, right? Or, oh, wouldn't you send them to a psychiatrist and get some medication? So this kind of information doesn't disseminate that as well already, because in your own practice, you're seeing what things that may work that for some reason other doctors just don't even wink at. It's what's that all about?
Yeah, it's exactly right. And I think part of it is that doctors receive such little training on sleep medicine. On average, 2 hours of education in med school, if that. Some schools don't even teach sleep medicine at all. There really is a lack of knowledge and understanding in this area. So for anyone who's watching, I highly recommend looking into imagery rehearsal therapy and into Dr. Krakow's research and his books, which we're going to talk about as well. And maybe this is a good time to segue into discussing what are nightmares versus night terrors or vivid dreams. How do you distinguish those?
Sure. Dreaming is a fascinating subject, and I was so fortunate this time in the 80s and the early 90s. I spent a lot of time interacting with the Association for the Study of Dreams, which has been around a long time, and dream researchers have been very interested in all of these aspects far longer than people in the fields of sleep medicine. So I learned a lot about their ideas that had a lot to say about REM sleep, because they were incredibly interested when REM sleep was discovered in the 1950s, because it tied in with the things they'd been thinking about already about dream sciences. So with that information, it became very obvious that you had to ask the question, what do dreams do? If you ask the question, are there bad dreams? Are there vivid dreams? Are there nightmares? Do they have purposes? And I think at baseline, I think it's very important to understand that dreams probably are a very important signal of rapid eye movement sleep, meaning that if you're not dreaming, there's probably something wrong with your REM. If you're having bad dreams, there could be something wrong with your REM. And if you're a normal sleeper, then you probably are dreaming pretty much every night, have memories of your dreams, can recount them, and most of the time they are pleasant. So those pearls I have found very useful because I'll ask people those questions like, do you dream? Do you not dream? What are your dreams like? It turns out that the people who have the disturbing dreams, and this is what we learned right away back in the uh, late 80s and early 90s, is that they clearly disturb their sleep. And you think that'd be so obvious, but people are just not connecting the dots. And we found that almost everybody who had a nightmare problem had insomnia. And of course, why wouldn't they be afraid to go to sleep and have a nightmare? Or why wouldn't they wake up in the middle of the night from a nightmare and not be able to go back to sleep? So that's now two disorders. That's nightmares that actually cause insomnia. And we said, wow, this is a big deal. The nightmares seem to be causing the anxiety and the depression and the PTSD severity based on the nightmare treatment research. And of course, the nightmares seem to be causing insomnia. Hey, nightmares are something really big. We should ask our patients about it and treat the problem because they will probably sleep better. So that's where it all started. The shock to my system was I was going through board certification in sleep at the time. So when I actually was doing all of this, I kept looking at these patients, and a really funny anecdote from a research perspective, they were getting huge effect sizes. When we would treat them with IRT, which by the way simply means asking somebody to select a nightmare, change the content, this is all while you're awake, and then picture that in your mind's eye for several minutes a day, and that's it. That's the treatment. It takes much longer to train somebody to do that if they're a PTSD patient for obvious reasons. That simplicity doesn't work with the complexity of the way they see their disorder. So when we make the distinction about whether or not a person is having a nightmare problem, our understanding is whether or not it is disrupting the sleep or not. A night terror, as one example, is very different. It usually comes in deep non-REM sleep. The person is often not aware of it. They have no memory of it from the next morning. They can be very disruptive in their sleep, lots of tossing and turning, shouting, talking, all kinds of activity. But if you say to them, what was that all about? Even if you try to interrupt them, they won't because they're half asleep or asleep. So nightmares are very different in that sense because you are remembering your dream content the next morning. And certainly if you wake up in the middle of the night, vividly remember your dream content. So making that distinction is important because night terrors often need their own sleep evaluation because they can mean various things that have to be evaluated by a sleep doctor if it's injurious, that the person is actually sleepwalking with their night terrors, tripping, falling, injuring himself, REM behavior disorder. All those kinds of things have to be evaluated by, obviously, a sleep doctor. But nightmares, many psychotherapists, psychiatrists can evaluate and come to the conclusion this looks like a nightmare disorder.
And then what is Nightmare Triad Syndrome? And that might be a term that a lot of clinicians are not familiar with. So could you explain what that is?
Certainly. So when we were discussing this point about how when we did the research with nightmares and we then saw there was a second disorder, insomnia, this was the point we were getting to in the early mid 1990s when I was finishing up board certification in sleep. And I couldn't believe this research finding. These individuals would come to us and say, I can't thank you so much. My nightmares are better. I'm sleeping through the night. I sleep so much better. But we would go look at something called the Pittsburgh Sleep Quality Index, which is a research tool. It's widely in use, and it's pretty good at measuring what's called sleep quality. And that was very helpful to us in our research development to try to understand sleep quality versus sleep quantity. And what happened was we would look at their PSQI score after they're saying to us, I'm sleeping so much better. And we're saying, wait, this PSQI score is still abnormal. In fact, it's very abnormal. Why are they sleeping so much better? And of course, if you go back to the score, you see the PSQI scores of PTSD patients are astronomical. If you know the scale, it's up like 12, 13, 14, 15. It's outrageous how bad their sleep is. We were getting them down to 10 or 9 or 8, which is very good. It's a huge change. Turns out normal is below 5. Normal is probably really closer to 2 if you look at all the data. So we said, what are we missing? And we started evaluating these patients and discovered that the largest majority of chronic nightmare patients had sleep apnea. And to this day, we now understand it that way. And that's why we use the term Nightmare Triad Syndrome. That most people with chronic nightmares, particularly those who've struggled with it, particularly those where the pills don't work, particularly those where psychotherapy doesn't work, or for those where IRT does work, but it doesn't make the sleep so much better that you've solved their sleep problems. And so those people end up having that. And the reason this research is so important is in the scientific literature right now, there are 9 studies that have evaluated treating nightmares with what? CPAP. And every single one of them shows that nightmares get better. Now, these are not the perfect studies. They're not randomized controlled trials, but there are some case studies and some of the cohorts are large, but every single one. We published the second one in 1990. Dajrami and Humans published one in 1998, a case report. And then several researchers have started publishing it just in the last 5 years. 9 studies all show the same thing. So you go, wait, what do we do with that information? What we do with it, that means that if you've got a patient with chronic nightmares, one of the things you're going to do, and you actually had a guest on your show not that long ago, a PhD psychologist, I believe, and I was so impressed with the way she was communicating with you about the kinds of same things we had been researching and publishing on for 25 years. I said she nailed it because that is correct. When you see a nightmare patient, don't just think prazosin or IRT. Go do the sleep study too, and then make a decision about how you want to go forward.
Again, for the clinician, for anyone who's listening, the idea here is we want to look under the hood to see what's going on. And I think one of the things that I see happen all the time in sleep or just in the community when treating sleep issues is people are trying to match up a treatment with the symptom without really asking, well, why are they having that symptom? Where is that symptom coming from? And so I think this is really compelling to understand that sleep disordered breathing can be underpinning many of these nightmare experiences for patients.
And you and I both have different types of backgrounds. You have a very broad background because you've chosen integrative medicine and psychiatry and sleep. I have a broad background because of internal medicine, emergency medicine, involvement in addiction medicine, and then finally sleep medicine. And so we bring to the table, in general, the concept of an open mind. And unfortunately, we're living in an age where so many silos developed over the last several decades. We have a tremendous problem with echo chambers where people are driven into what's called consensus medicine. And consensus medicine is often inferior. And some of us are now understanding that and recognize why the phrase personally tailored medicine is the operative way to function. And so many people are disgruntled by healthcare today because they're being approached by this is what the consensus does. This is what I'm supposed to do. I'm just following orders. And it sounds horrible because it is horrible. And it's a problem that's going to have to get fixed one way or another. I don't have the most obvious solutions, but knowledge is something you would think that healthcare professionals will be very curious to get. But unfortunately, they're battling against insurance companies, government regulators, and their own echo chambers that they have not learned how to break out of. And they have to do that to be able to hear this, to say, okay, all right, maybe I should be getting more sleep studies on these patients. But see, now that's where it gets very problematic because the way sleep studies are done and the way sleep centers are operating makes them feel like, okay, but I haven't had such good experiences with sleep centers.
Yeah, absolutely. And oh my gosh, we could do a whole series on just what's wrong with the healthcare system and what are the challenges that we're facing. And yeah, and again, for anyone who's listening, thank you for listening to this conversation because if you're listening, that means you have an open mind and you're open to learning. And this is how we
Exactly.
can change the system, right? By
Right.
providing this personalized care. With sleep studies now, with home sleep testing technology improving and becoming more readily available, again, clinicians, we can get sleep studies for our patients, and it's so much easier than trying to fight against insurance to get them an in-lab PSG. Okay, with Nightmare Triad Syndrome, are there specific patient populations that are more vulnerable to this syndrome?
Yeah, it's a great question because it comes back to these ideas about what is PTSD? Is PTSD strictly a diagnosis and a psychological disorder, or is it more what we're learning about so much to do with emotional processing inside the body, so much to do with hyperarousal physiology? There's so many processes that are going on there that make us say, no, this is not a simple disorder. This is really complex. And of course, the complexity that I know the most about from my background is the sleep aspect, and that how many of these people suffer from horrible sleep fragmentation. So once you start to see that, and once you see the complaints, and this is what happened, these nightmare patients were coming to us and we were treating them with IRT. And then we did some research showing, let us do some CBT-I for your insomnia and some IRT for your nightmares. And we're thinking, wow, we're really cutting edge here. But then we go, but no, we're missing that third leg. And so who were these people? These were the people who, in many ways, were the worst PTSD cases. In other words, their severity level said to us, oh, wait, this is why we get, what are we missing? And in them, it turned out to be more severe sleep apnea. And the sleep apnea was very meaningful, even though sometimes it was severe upper airway resistance and not just sleep apnea. We published a paper on Nightmare Triad Syndrome in a European respiratory journal in adolescents who were at risk, long history of drug problems in the past. They went to the specialized charter school in Albuquerque, and we separated them into two groups, and it was night and day. The ones who would have met the criteria, and this was subjective, we didn't have the facility to do sleep studies at that time for this cohort, but we could tell from various symptom loads that this group had nightmare triad syndrome with high probability, and this group had very low probability. And night and day difference for symptoms: worse depression, worse anxiety, worse PTSD, worse sleep, worse nightmares, worse insomnia, just everything worse. And so that's one of those big red flags. If you've got a patient that you're on now their third different drug you've tried them for PTSD, or your third different drug you've tried them on insomnia, we want those doctors to scratch their head and say, there must be something else going on here. And that's when they're going to say, you know what? This may be one of these nightmare triad syndrome cases where they've got sleep apnea, and I want to do more for my patients, so I want to get that sleep study. So that's a very prime example of how they would spot it. In general, even if it's not nightmare triad syndrome, if it's just a person who comes in having taken too many medications, on too many medications, and in particular, when they tell you the question, they answer the question of, well, how's your medication doing? And they go, I take it because the doctor told me to take it, but I was expecting a better result. That's a huge red flag that something else is going on.
Okay, that's really helpful. And okay, so let's say that I'm the doctor and I've got this patient coming to me who is struggling with nightmares. What would you recommend as the first steps that I should do as the doctor?
I love the way you asked the question because you see, in that setting, you want the doctor, therapist, whomever, to say, tell me what these nightmares are doing to you. I want to know. In other words, instead of saying, oh, let's talk about your PTSD or your anxiety, depression, tell me about that nightmare complaint. You'd be surprised, or maybe you won't, but not a lot of people will come into any clinic anywhere except maybe a few specialized mental health clinics saying, okay, I want to talk about my nightmares today. They certainly don't come into a sleep center and talk about it. They don't even come into psychiatry clinics necessarily and say, okay, my chief complaint is nightmares. You have to tease it out a little bit. But once you've got that on the table, all right, how is the nightmare affecting you? And these people will go on. No, I can't sleep. I don't want to sleep. I wake up at night. I feel horrible. I walk around in the house. I'm afraid to go back to sleep. I drink. There was research done years ago showing that nightmares, in all probability, lead to a huge proportion of alcoholics, that they get up and they drink to go back to sleep. And there was data on that in scientific journals in the 1980s and 1990s. I don't know that anybody's ever done anything about it, but alcohol is a primary method therapy for nightmares and for insomnia. If that patient talks to you, now you as the provider, the healthcare professional, you go, wow, this is really interesting. This person is describing this disorder that really is impacting their life in so many ways. I never realized that before. Let me keep working with them on their nightmares. Let me see if I could use IRT with them. Let me see if they're a candidate for prazosin. Let me keep asking more about their symptoms to find out if these nightmares are actually what's causing their anxiety, depression, and PTSD to be getting worse. And then ultimately, of course, you go, if it's that bad, could this be one of those cases where they have a sleep breathing condition as well? That last part is very tricky in these patients because we stop asking questions about sleep breathing symptoms years ago. Sleep breathing symptoms are very unreliable in trying to help understand whether somebody has that condition. So we moved on to a whole different pathways, of which you can discuss later if you like. But that's a lot of how we dealt with that complexity.
Excellent. Yeah, and there's so many tools available and they don't have to be complicated, is what I'm hearing. That it's just about asking good questions, really
Right.
understanding the person in front of you. Even IRT, imagery rehearsal therapy, it's not that hard actually, and clinicians can learn to do it or they can refer to trusted colleagues, psychologists or whatnot.
And based on our research, we actually know that IRT does work in somebody who has sleep apnea. So it's not like you have to say, oh, you've got sleep apnea. I can't. No, you can do that. You can do CBT-I as somebody who has sleep apnea. You've got so many tools that you can do that help patients that would allow a person to respond dramatically and not necessarily require medication. So it's remarkable progress that we're making that unfortunately has not been widely disseminated.
Yeah, I absolutely agree with that. And I think one of the challenges that I hear a lot from my colleagues is I don't know where to send my patient for CBT-I or I don't know where to send them for IRT.
Absolutely.
What would you recommend?
I'd recommend my book. My book and the other book before it, Sound Sleep, Sound Mind, have very advanced, I would call variations of CBT-I. In fact, I'm publishing a new book next month called Fast Asleep. And it's an advanced guide of sleep hygiene where I have meshed sleep hygiene with CBT-I. And it's a great book for patients, a great book for providers. This dilemma doesn't have an easy solution. I know there are online programs, and I'm sure some of them are good because I know some of the people who are doing them. But this is a thing that's in, what do you call it? It's a problem in search of a resource. And there's no great resources out there that are providing what's needed because I'm not sure, maybe artificial intelligence will do it one day. That is conceivable. But there's so much personal tailoring that has to be done with good CBT-I. You can do CBT-I and make somebody's insomnia worse. And I've seen that much more than I would have wanted to admit. And it's very scary that people can't learn it and actually provide it. I don't know why that is. These are people that are sleep doctors and don't do it right. That's odd, in my opinion. So that is a obstacle to care because we're talking about something we think should be simple. And for you and I, it probably is. But there's not thousands of CBT-I practitioners out there that are reliable and can be trusted to do the work. But worse, nobody would be sending them to them anyway, because they don't know that. They think it's insomnia, so don't you just give them a sleeping pill? So this is a huge empty space, void, needing to be filled, and it's not clear to me how it's going to get filled. It is really nice to have a book that gives you a lot of information, and we're living in a do-it-yourself age. So yes, you can learn lots of things from a book and you can apply lots of things. But whether or not that will do it for the most complex patients, that's not clear. And that's why personally tailored medicine means getting these other therapists, getting these other psychiatrists, getting the other sleep doctors to recognize there's so much more complexity to the patients you're dealing with. Don't keep thinking you've got to refer them here or there. Find out what you can do, where you can learn that skill. You can learn that tool, and now you can be the one who does it. And by the way, if you do that, you may not get rich, but you're going to be very secure in your job because everybody's going to send their patients to you.
That's exactly right. And these skills that we're talking about with CBT-I, even clinicians can learn those skills and you can easily learn. That's what this channel, my programs are all about, that about teaching this to clinicians so that you can implement this with the patients in front of you and really tailor it to them. And it doesn't have to be complicated, but it's just about listening and understanding their needs and meeting them where they are. And some simple tools can make a huge difference for patients with insomnia and sleep disorders.
That's great you're doing that. Thank you.
Yeah, no. And so when I was in my psychiatry residency, our chairman used to always say, there's ECT and there's ECT, meaning there's a lot of bad ECT happening out there, but then there's the right way to do it. So I always think
Right.
about that with CBT-I. There's
Yeah.
CBT-I and there's CBT-I, where
Right.
it's really
Right.
effective. So
Right.
I wanted to just go back to the substance use piece that you were talking about. These patients who are maybe using alcohol, or maybe they have a co-occurring substance use disorder. How would you suggest that we approach those patients? And we see that a lot with patients with PTSD, right? They may be using
Right. Right.
cannabis, alcohol, or other substances. What's a good way to approach those patients?
The biggest one is opiates, because you've got this combination in PTSD where many of them are pain patients and then they're on the opiates. And of course, if they're on opiates, that means they have sleep apnea. Period. End of sentence. The research on opiates causing obstructive breathing events, causing central breathing events, it's absolutely conclusive. If you're on one of these drugs for a long time or even just a few months, your breathing starts to get compromised. Now it has to do with another huge barrier, because I'll give you an example. I'm working at Gateway Behavioral Health in Savannah, Georgia, and they have a psychiatry residency training program. And many of their patients, they also have an addiction center there. So therefore, they're going to have a lot of people with sleep apnea. But so many other centers around the world, what do they do about it? Do they do? And they're grappling with this question. Do you open your own sleep center? Do you send patients to sleep centers? Do you find a way to do home testing? None of these questions have been answered yet. And this is this whole problem about what do providers do? Can you, on your own, set up your own home sleep testing system within your own clinic? My hunch is it's going to have to come to that. And it might come to it in an even simpler way, which is that the wearables that people are developing now and the entrepreneurial technological spirit is probably going to produce something sooner. And it's already done something like this, but it's going to get really good in a few years, probably, where you could just do a home test that you bought at Amazon. That's it. Or your primary care doctor bought it from Amazon and said, here, take this home. And now you get your diagnosis. You're done. This is it. We know you have sleep disordered breathing. You don't need to go to a sleep center. You need to get that diagnosed. Now, the question is, how do you treat it? Now, the one thing I want to get across here that I found invaluable in the cohorts we're talking about is something that I delve into in great detail in the Life Saving Sleep book, and that is what we call early conservative treatment of sleep disordered breathing. And the reason for that is, as I got to interact with all these patients, I saw in the personal tailoring model how many of them were not ready for PAP therapy, even though we had found a way in our work in 2005 to stop using CPAP and only use bilevel and other advanced devices, we knew even that was scary for these patients. And we also knew that if you're trying to deal with insurance companies and getting them through all these hoops, these patients don't want that aggravation. They're not ready for that. And so this helped us, even though at our center we had developed a model, I'll explain that another time, where we could get people on advanced PAP therapy very easily. We found it very easy, never got rejected by insurance companies. But this model was designed for helping people understand that if you want to get somebody to have buy-in about a sleep disordered breathing problem, there are several simple things you can do that are like magic. The first one, we tested it in the early 2000s. There's a randomized controlled trial of people with chronic insomnia who walked in the door. They had moderate to severe insomnia, and they told us there was nothing wrong with their sleep breathing. We divided them into two groups, gave one group nasal strips because we knew, despite what they knew, without testing them, there was something going on with their breathing. And then the other group just was educated on, I think, sleep hygiene or something. No, I'm sorry, not sleep hygiene. It was basic education about sleep, but not sleep hygiene. And this group that got the nasal strip, not only statistically significant, but 75% of these chronic insomniacs, that's like 7.5 out of every 10 of the insomniacs are saying, my sleep is noticeably better. The insomnia severity scores are cutting in half, just remarkable with a nasal strip. And we're going, that's very interesting. So that embarked us on a whole parallel career. All the while that we were doing all our sleep disordered breathing research, we were looking at everything to do with the nose, nasal hygiene, allergic rhinitis, non-allergic rhinitis, vasomotor rhinitis, swollen turbinates, deviated septums. We would never stop looking at that at the same time because we realized if you're going to use a PAP machine, you got to get the nose to work. And so the early conservative treatment steps we learned, and I published in the book on my website, BarryKrakow.md.com, there's a free video series. It's a 1-hour video series called The Nose, N-O-S-E, Nose, K-N-O-W-S. And it goes through a lot of this. The books, of course, go through more. And we have been stunned by the way we can interact with anybody. Like we could be at a party. We meet somebody at a party and they have a conversation with you and they go, oh, you're going to talk to me about CPAP. No, you asked me a couple of questions. I'm going to tell you what to do. And they listen to me. They go, oh, you're ridiculous. I say, no, just listen. Go get a bottle of nasal saline. Squirt it in your nose a few times a day for a couple of weeks. And then come back and tell me what happened. So we learned this in the 2000s. We're going like, these people come back and they go, wait, you wanted me to clean my nose for what reason? Because I'm sleeping better. Was that what you wanted me to do? I say, yeah, that's the whole idea. If you get your nose to work, you're going to be able to sleep better. So that was 20 plus years ago. And then we're doing the nasal strips, nasal dilators. And then we investigated a tremendous amount of energy in all of the nasal sprays because there's so much mileage to be gained. And there was early research showing that people that use Flonase actually had a reduction in their apnea hypopnea index. So these things actually treat sleep disordered breathing the earliest, simplest way. And what does it do to the patient? Like, I'm sleeping better. You've sold me. This is interesting. Tell me more. What else do you have to offer?
It's so amazing how these simple things make such a difference. And thank you, Dr. Krakow, for all the research that you've done and really laying the foundation for our practices, because that's one thing I learned in my sleep medicine fellowship. Like our program director, he had us always recommending nasal saline sprays to our patients. That was part of our standard treatment plans, and that comes out of your work and your research. So thank you for all of the work that you've done. As we wind down, I feel like we could go on for hours, but to wind up here, maybe a couple of other questions. Are there any rating scales that you recommend to the average practitioner to be using with their patients, whether they're assessing for nightmares or sleep apnea or something else? Yeah, so what would you recommend that primary care doctors and psychiatrists use?
So there's a simple rating scale and there's a little bit more complex. Either one can work. The simple one is just a few questions. Do you have nightmares? Meaning, do you have disturbing dreams? Because nightmares gets confusing terminology. Do you have bad dreams? Do you have disturbing dreams? Do you have them once a week or more? And do they disturb you? Like, do they actually disturb you the next day, that next morning? Do they disturb your sleep? That's enough. Right there, you've just made the diagnosis of nightmare disorder. The chances are that person is struggling with that nightmare problem. If you want something more formal, it's pretty easy. We put together something called the Disturbing Dream and Nightmare Severity Index. It's 5 questions. I'm sure it's online in 1,000 places. And you'll see it describes questions like how often you have the problem at night, how many actual bad dreams do you have, how would you rate the severity of your bad dreams, how would you rate the intensity, and when you put that all together, you're getting a sense of, oh, this looks like it's about a 10, because 10 comes out to be about a nightmare disorder based on the validity stuff that we did about 19 years ago. So you see DDNSI, Disturbing Dream Nightmare Severity Index, in a lot of nightmare treatment research. So it's very common to use. It's easy to use in a clinic if you want. But as I said, you can also just ask the questions. I
Great.
should mention that my wife and I put together in 2002 a training manual. It's so funny because we did this specifically for nightmare patients. It's called Turning Nightmares into Dreams. It's a 100-page workbook. It's a lot of fun. It's got a lot of pictures in it, a lot of things to do. And it's got about 2.5 hours of audio. And we thought the people who were going to get it were the nightmare patients. But the people who bought it were all the psychotherapists, especially the ones working at VA medical centers who wanted to learn how to do IRT. So after that became popular, we decided that I would also do an IRT video. It's 2.5 hours long on my website, barrykrakomd.com. And that video is actually me running through a 4-session group treatment for chronic nightmares. And for the person who's interested in group, I would point out that one of the most satisfying experiences you can have is doing group treatments for nightmare patients, because it's so much fun and so interesting to hear their interactions with each other when they're battling about the idea that you can treat nightmares. What do you mean you can treat nightmares? My doctor told me that I have to treat my PTSD. My doctor told me only medications will work. And you're in there with these people, 5, 10 people at a time, going over this discussion. Those are very interesting theories. And I'm glad that you've heard those theories. They could have a lot of validity to them, and that's true. But here's a new theory. It's a non-drug therapy called IRT that talks about a different way to approach nightmares as an independent disorder that can be treated. If you want to do group treatment with nightmares, I totally recommend that as a skill for your psychotherapists that are listening. It's a wonderful methodology to learn, very satisfying, and of course, incredibly effective.
These are such great resources, and I'm going to put the links to all of these in the video description underneath this video. For listeners, you can go down and you can click through the links to Dr. Krakow's website and his books and the other resources that we've discussed. And a couple last things. Are there any new emerging areas of research or therapies that are exciting with regard to treatment of nightmares?
To my knowledge, not in the sense of something I've had any clinical experience with, but the fact that, again, from an entrepreneurial perspective, there's so many people coming up with things that they want to try. For example, I know somebody has a tool out there, and I forget the name of it, but their goal is to try to predict when you're going to have a nightmare. So then something will buzz or do something on your hand and you'll wake up and now you won't have the nightmare. I don't know if that's such a great idea, because that's not looking at why you had the nightmare, which again is often related to sleep breathing problems. On the other hand, I am a firm believer of letting technology try to find these solutions. And if this would work and help people, then I'm all for it. That's the only one that I've heard about. I know there's always variations of IRT that come out from time to time, somebody developing some other style, and that's great. It's not like we have a patent on IRT. It's your mind's eye that's actually doing the work. So if you've got a better way of accessing it, that's great.
Are there any other thoughts that you'd like to share with the audience about nightmares or anything else maybe that I didn't ask about or we didn't have time to touch on today?
So the only two things that might come to mind are that one, it is so important to take seriously a person who says they have bad dreams and go into those questions so that you're saying, gosh, this is really disrupting your life. And then a healthcare professional who starts to do that will start interacting with those patients differently. So, wow, yeah, I know what it's like. In fact, when I was doing my early training, I prayed that I would start having nightmares because I wanted to be able to experience how bad this was. And so I got my prayers answered, not chronic nightmares, but I'd have nightmares from time to time. I go, thank you, Hashem, for letting me see it, just how awful this is for these people. And they would be having them every night or three times a night. I'm going, wow. And taking nightmares seriously is so important. And we're just not taught to do that in any kind of training. The second thing is just the whole business about sleep. The fact that sleep is so important, it should never, ever be thought of something as secondary. It's always a primary pillar of somebody's mental health. Could you get somebody who comes along who has a perfect response to their sleeping pill and they're doing great with it and they go, my sleep's fine? Yes, of course. So you don't have to worry about that, although research just came out 2 weeks ago by the people who discovered the glymphatic system, showing that Ambien causes brain damage or prevents the glymphatic system from working, so therefore causes brain damage. You go, all right, maybe you're not having such a great response. But nonetheless, there's so many people that are not getting great responses to their sleep. And that pillar, the more any professional invests in helping that pillar get better, they're going to see their patients get better. And that's everybody. The cancer doctor doesn't get to see all their patients get better. An internist doesn't see all their patients get better. But sleep doctors are one of the few groups where you see a lot of patients get better. It's very satisfying work. And just if you think of the overlap with all the other fields, you're doing a tremendous service by helping somebody get their sleep in order. But it takes more knowledge and it takes thinking out of the box and being very curious to want that information so you can apply it.
Thank you, Dr. Krakow. This was so illuminating, and you shared so many pearls of wisdom today. I learned so much, and actually, I'm going to go and revise my intake forms that I use in my practice, and I'm going to add a few questions about nightmares because I don't think we have any questions about nightmares in there, surprisingly. So I'm going to go and do that today. That's my action item. And so for anyone who's listening to this, let me know in the comments below, what are your action items that you learned in today's discussion? Dr. Keiko, where can people learn more about you and where can they get your books?
Thank you. My books are, I think, pretty much everywhere. Amazon obviously has all the books. I think all bookstores online have them. Life Saving Sleep is the most recent book. Sound Sleep, Sound Mind was written some years ago, but also is still very good for mental health professionals as a tool. And the new book, as I said, Fast Asleep, is coming out, I believe, next month. On the website, BarryKrakowMD.com, it's also a place to buy the books, also videos, the Nightmare Treatment Manual. And through that website, I do something that is called sleep health coaching, because I do a lot more of that now than practicing sleep medicine. And that is about individuals mostly who've gone to other sleep centers or gone to other mental health facilities, and they've not gotten the answers they've wanted in terms of knowledge. And so their treatments obviously are not working that well. And I'm not treating them, but they're asking me the questions. Here's how the doctors evaluated my sleep test. Here's how they taught me CBT-I. Here was their approach to restless legs and leg jerks. Here's what their thinking was about my PTSD. and so forth and so on. And I go, all right, let me tell you what I know from working with thousands of people just like you, because that's almost always the case. Let me give you that knowledge base so you now can take that information and go back to your healthcare professionals and say, I would like to try these additional steps because I think these steps are ones that we've been missing. And I'd like to think this information is being transmitted back to the healthcare providers in this way, and the knowledge is getting disseminated. I will tell you absolutely that sometimes those healthcare providers are disturbed by hearing the fact that somebody was told a different way, and that provider then says, you should go someplace else then because I don't do that. I'm not interested in that. And again, this is this echo chamber consensus medicine problem that is crushing medicine right now and causing problems that people, and not all medicine, but certain fields are very problematic. Psychiatry is one in particular because it's not adopting a sleep medicine perspective very much at all. So the sleep health coaching is something that I do. I have a free Substack newsletter called fastasleep.substack.com. And I think that's it.
Thank you again, Dr. Krakow. And again, I'll put all of those links underneath this video so people can go check them out. And I so appreciate your time and your generosity today. And please come back anytime.
Thank you very much for the opportunity.